I am going to present everything about backache, diagnosis and treatment of back pain. Backache is a common term to describe back pain. Back means spine or vertebral column. Spine or vertebral column consists of 33 vertebrae which protect the 45 centimeter long spinal cord inside the spinal canal. The spine is further described as five parts: cervical spine, dorsal spine, lumbar spine, sacrum, and coccyx. The cervical part of spine is in the neck and consists of 7 cervical vertebrae. Cervical part of spine is very mobile and normal person moves the neck for about 85,000 times in a day. So one should be careful in protecting the mobile part of spine which contains cervical segment of spinal cord and the nerves which supply the both upper limbs. Dorsal part of spine is relatively less mobile as compared to the cervical and lumbar segments of the vertebral column. Dorsal spine or thoracic spine lies on the posterior aspect of the chest. Dorsal spine consists of 12 thoracic vertebrae. Because there is less movement of the dorsal spine, so there are less chances of spondylotic changes and prolapse of the intervertebral disc in the dorsal spine. So the pain on the posterior aspect of thorax or chest may be due to some infective lesions like tubercular spondylitis or some tumors like intradural extramedullary tumors which are neurofibroma or meningioma. Lumbar spine consists of 5 lumbar vertebrae. The junction of dorsal spine and lumbar spine, that is the L1 vertebra, is very crucial. The spinal cord ends at the level of L1 vertebra, and this part of spinal cord is known as conus medullaris or conus. All nerves roots are condensed at this level as like tail of a horse. So this bunching of spinal roots at the level of conus is known as cauda equina. Lumbar segment of spine provides weight bearing of the body. Whenever someone falls from a height, there is a risk of vertebral body collapse of L1 vertebra. This trauma can damage conus medullaris or the cauda equina, leading to weakness of both lower limbs, that is paresis or paraplegia, along with involvement of bladder and bowel. There are 5 sacral vertebrae which are fused together to form sacrum. Coccyx or tailbone. There are 3 coccygeal vertebrae which are rudimentary in humans as there is no tail in human beings. Sometimes there is pain in the coccyx which is known as coccydynia. The person feels pain on sitting on a hard surface. It may be due to arthritic changes or because of trauma. Pain which may occur at any point in spine is known as back pain. If it involves cervical part of spine, it is also known as cervical pain or neck pain. If pain occurs on the lower back, it is called lower backache, and if the pain radiates along with the posterior aspect of leg, it is known as sciatica because sciatic nerve is a major nerve of the lower limb. In lumbar canal stenosis, pain occurs in lower limbs on prolonged walking due to involvement of the nerve, and it is also known as neurogenic claudication. Spondylosis is a degenerative process, and incidence of spondylosis increases with aging. With aging, there is a wear and tear on the vertebrae, bones of the spine, and the disc between these vertebrae. In between adjacent vertebrae lies the intervertebral disc. Disc is a soft to firm structure and consists of a soft core known as nucleus pulposus, which is surrounded by annulus fibrosus. Bony outgrowths are called osteophytes or bony spurs. Osteophytes and prolapsed discs cause compression over the nerves, blood vessels, and spinal cord. What causes spondylosis? Spondylosis is a degenerative disease. Increased stress over the vertebrae causes protrusion of the intervertebral disc, calcification of the ligaments, and osteophytes formation. Osteophytes are the abnormal bony projections. The primary function of the vertebral column is to protect the spinal cord and allowing movement. But when degenerative process progresses, adjacent vertebrae tend to fuse in order to protect spinal cord at the expense of the mobility of that spinal segment. Stress over the vertebrae is mostly increased by prolonged work in sitting posture, lifting weight over the head, wrong posture, or trauma, or due to old age. Cervical spondylosis is a chronic degenerative process. Degenerative disease of the cervical spine is a common cause of locomotor disability in patients over the age of 50 years. Cervical spondylosis results from progressive biomechanical stress and strain over the cervical spine and can be compounded by repeated traumas. Spondylosis or degenerative disease of spine involves disc degeneration and is accompanied by facet joint osteoarthritis and ossification of the posterior longitudinal ligament. There is a gradual decrease in viscoelasticity of the nucleus pulposus and reduction in disc volume and height. Common symptoms of cervical spondylosis. Cervical spondylosis causes neck pain and stiffness and may extend to the shoulder, upper arms, hands, and back of head. Other common symptoms are numbness, that is, loss of feeling of touch, tingling, or weakness in the arms, hands, and fingers. Neck pain may worsen and there may be associated headache and dizziness. Pressure over the spinal cord causes muscle weakness, muscle spasm, and weakness of the lower limbs. How to recognize cervical spondylosis? Any person who feels neck pain or stiffness of the neck muscles or sensory deficit or weakness of the limbs should consult a doctor. X-ray of the cervical spine and MRI of the cervical spine are required to diagnose cervical spondylosis. Sometimes some other investigations are also required, like nerve conduction studies. What are the treatment options? Simple analgesics like diclofenac, tramadol, aceclofenac, ibuprofen can help in the alleviation of pain. Physiotherapy, restriction of neck movements with cervical collar can provide relief in early stages of cervical spondylosis. Hot fomentation and some topical analgesic gel like diclofenac gel, gabapentin gel are also helpful in pain relief. Neurotropic vitamins like methylcobalamin, pyridoxine, vitamin E help in neural compression or in neuropathy. Tablet like gabapentin 100 milligram or 300 milligram or pregabalin 75 milligram at night along with methylcobalamin helps in treatment of cervical spondylosis. Anti-spasticity drugs like tablet baclofen can be given twice or thrice a day in an adult or tablet tizanidine 2 milligram. It is needed if there is stiffness of the body which may be due to cervical spondylotic myelopathy. Myelopathy is the in spondylosis is the damage of the spinal cord due to prolonged bony compression. It is very often seen in late stages of cervical spondylosis. These patients may present with weakness of all four limbs, that is quadriceps, along with spasticity or stiffness of the limbs with bladder and bowel involvement. Neurosurgical interventions for treating severe cases of cervical spondylosis include cervical spine discoidectomy and fixation. Cervical spine laminectomy or laminoplasty is also a neurosurgical option. Surgery decreases the risk of developing myelopathy, that is spinal cord damage, in severe cases of cervical spondylosis. There are various operative procedures for treating the degenerative disease of cervical spine. Various types of neurosurgical procedures can be grouped widely into two categories: anterior and posterior approaches. Sometimes surgery is required if patient does not improve with conservative treatment. Neurosurgical operations are required to treat disc prolapse, canal stenosis, and myelopathy and other forms of cervical spondylosis. Operative intervention prevents the further neurological deterioration in severe cases of cervical spondylosis. The anterior approaches of cervical spine surgery are anterior cervical discoidectomy or discectomy. Anterior cervical discoidectomy can be done alone or it can be done with grafting. Graft may be autograft or allograft. This multiple several types of disc processes are available in the market. Anterior cervical discectomy with grafting and plating. Another option is anterior cervical carpectomy with adjacent discoidectomy with cage and plate and screw fixation. Anterior cervical discectomy with fusion ADCF is regarded as the gold standard for treatment of cervical disc disease. The anterior approaches came into practice in 1950s. Bailey and Wesley performed first anterior stabilization of the cervical spine in 1952. In 1955, Robinson and Smith described their method to stabilize cervical spine disc disease using iliac bone graft. Later in year 1958, Dr. Ralph Cloward published his technique of anterior cervical discectomy and fusion, that is called Cloward technique. For a single level degenerative cervical disc prolapse of intervertebral disc, sometimes anterior cervical discectomy of a single level may be sufficient and there will be no need for corpectomy and fusion. There is a lot of evidence in support of various additional procedures like anterior cervical discectomy with grafting or is anterior cervical discectomy with grafting and plating. Anterior cervical discectomy with artificial disc, that is called disc prosthesis, or corpectomy with adjacent discectomy with grafting, with plate and screw fixation, or with cage to plate and screw fixation. There are various modalities of surgical approaches of treatment. In traumatic cervical spine discectomy, fixation must be done. The posterior approaches of the cervical spine surgery are laminectomy or laminoplasty. These approaches are more suitable for multi-segmental cervical spondylosis. So there is a question, can we prevent cervical spondylosis? The precautions can prevent progression of this degenerative disease process. Person should be asked to improve posture and avoid vigorous neck movements. Use of a firm chair and sitting with a straight back should be encouraged. One should sleep without a pillow or very thin cervical pillow or wear a soft fabric collar. If doctor has prescribed hard cervical collar or Philadelphia cervical collar which ensures external immobilization to an extent, it should be used regularly. It prevents the further neck movements. One can prevent some neck injuries which might help to prevent further risk. Wear protective headgear for contact sports, use seat belts in vehicles and keep headrests at proper height. Excessive movement and neck injuries to be avoided. One should avoid lifting a very heavy object over his or her head. The jerky massage or chiropractic practice may damage the cervical spine. Regular exercise of the neck prevents the occurrence of cervical spondylosis. Contact sports like wrestling, football, etc. increase the risk of neck injury, so people with spondylosis should avoid contact sport. Regular intake of neurotropic vitamins like vitamin B6, B12, vitamin E. One should also wear a cervical collar which prevents further deterioration. Lower vitamin D3 level and low calcium intake also cause osteoporosis and increase arthritic changes. So if serum vitamin D3 level is low, tablet or capsule of vitamin D3 of 60,000 units to be prescribed once or twice a week for a month, and then once a week for a month, and after that in each tablet in 2 weeks for 4 months. It should be followed by again investigation of serum vitamin D3 level, and to prevent the osteoporosis, sometimes a daily tablet of calcium 500 milligram along with vitamin D3 of 2000 units to be given for a longer period. The rehabilitation options for patients with spondylosis are the physiotherapy measures like isometric exercises, transcutaneous nerve stimulation, ultrasonic diathermy help in rehabilitation. Lifestyle modification, certain changes in the posture like using appropriate chair, hard bed, etc. also provide relief. Some other abnormalities of the spine may also present with backache. One common abnormality is craniovertebral junction anomaly. Sometimes developmental abnormality of the craniovertebral junction, that is the junction of the skull and the vertebral column, also prevent present with neck pain or backache or weakness of the body. The craniovertebral junction is the bony junction of the skull and vertebral column. Four bones form this junction, that is clivus, occipital bone, C1 and C2 vertebra. The CV junction normally may be genetic or acquired. The bony changes associated with CV junction may cause compression over the medulla oblongata or upper spinal cord. The craniovertebral junction area is important as any abnormality in this area may lead to compression over the cervical cord or medulla oblongata, or that is the junction cervicomedullary junction, which is a junction of cervical region of the spinal cord and medulla oblongata. This is the picture which shows the relation of the clivus, occipital bone and C1 C2 vertebra where the cervicomedullary junction lies, and brain stem continues as the spinal cord. As I described the simple diagram of the sagittal view of the craniovertebral junction, transoral odontidectomy surgery is done through oral cavity. Anterior arch of atlas vertebra, that is first cervical vertebra, lies just anterior to the odontoid process of the axis, that is the C2 cervical vertebra. Any dislocation of atlantoaxial joint, that is atlantoaxial dislocation or AAD, may compress over the medulla oblongata which lies just posterior to the dens of the C2 vertebra. Different types of x-rays like open mouth view, lateral view of CV junction in neutral flexion and extension is required for the diagnosis of CV junction. MRI of the cervicomedullary junction is the investigation of choice. Sometimes MRI of the other part of the spinal cord is also required because there may be syrinx formation. This image very much explains the ligaments at the cervicomedullary junction or craniovertebral junction at the labella foramen magnum, different ligaments. These are the different bones at the craniovertebral junction, that is a clivus, C1, C2 vertebra and occipital bone. Different terms are used to describe lumbosacral degenerative disease and its symptoms. Lower backache, low back pain, lumbago, lumbar spondylosis, PIVD, prolapse of intervertebral disc of lumbosacral spine, sciatica, spondylolisthesis, and lumbar canal stenosis. Lower back pain is a very common complaint in all age groups. We all have experienced back pain at some time in our lifetime. Sometimes it persists and affects our routine and becomes a matter of concern. But in fact, most of the times it is just stiffness or muscle strain due to hard work, prolonged standing, strenuous exercise, play, or after lifting a heavy object. Such back pain is not due to any underlying disease. Mild or moderate level of pain gets relieved by taking analgesics, like an adult may take diclofenac 50 mg after a meal or SOS and after taking rest. The other causes of backache are muscle sprain, muscle pull, strain, wrong posture, etc. Pain is a subjective sensation and complaint of backache may vary from person to person. For example, for an athlete, the lower backache after a prolonged run or play may not be of great concern, but similar intensity of pain may be very debilitating for an old age person. So, mild back pain, which can be explained on the basis of obvious cause like prolonged walk and play, should not be investigated. Bed rest is the best medical advice for relieving backache. However, severe persistent backache without any obvious precipitating factor may warrant a consultation with medical specialists. Orthopedicians, physiotherapists, sport medicine physicians, neurologists, pediatricians, and neurosurgeons commonly encounter patients with complaints of lower backache. One of the common causes of lower backache is spondylosis, which is a progressive degenerative disease of the spine. With aging, the water content in the intervertebral disc, ligament, and bone is gradually decreased and it restricts the movement of the spine. This picture shows the entire vertebral column. Upper part is the cervical spine, middle part is thoracic and lumbar spine, lower part is sacrum, and lowest part is coccyx. Lumbar spondylosis is a medical term to describe a degenerative disease of the lower part of the vertebral column, that is the region below the rib cage, consisting of lumbar and sacral region. There are 5 lumbar vertebrae with intervertebral disc between two adjacent vertebral bodies. So, progressive wear and tear of this region may cause different types of diseases Lumbar spondylosis may lead to lumbar canal stenosis, prolapse of the intervertebral disc, and spondylolisthesis. Our vertebral column consists of vertebrae and the intervertebral disc, which are strengthened by many ligaments. The vertebral column contains vertebral canal. Within this bony canal, a 45 centimeter long spinal cord is contained. The spinal nerves come out through the intervertebral foramina, which are bordered by disc, pedicle, vertebral body, and facet joints. So, any abnormality of the disc or facet joint or vertebral joint leads to narrowing of the intervertebral neuroforamina, which compresses the spinal nerve, causing pain and later the neurological deficit. It is lumbar spondylosis is due to increased stress over the lumbar vertebrae, which causes protrusion of the intervertebral disc, calcification of the ligaments, especially the ligamentum flavum, which is situated just posterior to the dural sac, and osteophyte formation. Osteophytes are the abnormal bony projections, beak-like structures projecting from the vertebral bodies. Stress over the vertebrae is mostly due to increased body weight, sedentary lifestyle, wrong posture, and old age. Due to many risk factors, the disc may age prematurely and dries up, that is called disc desiccation, leading to narrowing of the disc space. This in turn decreases the flexibility of the spine and osteophyte formation in the vertebral bodies. Nerve compression causes nerve edema, alteration in nutritional transport along the nerve, and local inflammation. Therefore, the bed rest and anti-inflammatory medication relieve pain. Lumbar canal stenosis is commonly a disease of the old age and commonly occurs due to hypertrophy of the ligamentum flavum. Ligamentum flavum is about 5 mm thick soft ligament on the posterior aspect of the spinal dura. Due to thickening and calcification of this ligament, the spinal canal gets narrowed in cases of lumbar spondylosis. Patients complain of pain in lower back, that is called claudication, after walking for a long distance, that is a claudication distance. Gradually this distance decreases and person starts experiencing pain even after walking for 100 meters. In patients with lumbar canal stenosis, pain gets relieved on taking rest or in sitting position. There is no pain on bending. In this way, pain due to lumbar canal stenosis differs from pain due to PIVD, prolapse of intervertebral disc. Pain due to disc prolapse usually increases on bending. Prolapse or bulge or protrusion of the intervertebral disc causes compression of the spinal nerve, which causes lower backache. PIVD causes pain in the legs and sometimes bladder and bowel symptoms. Pain in the lower back is usually caused by muscle strain. It may also include sciatica, that is the pain that radiates from back of the buttock down into the legs. Pain may occur immediately or after some time after physical activity. In patients with lumbar spondylosis due to PIVD, pain and stiffness may be continuous or only occur when person is in particular position. The pain may get worsened by coughing, sneezing or on bending. Even sitting may induce pain. Such type of lower backache is relieved only when patient lies on bed in certain position. Spondylolisthesis is another type of degenerative disease of spine. The one vertebral body is slipped over the another vertebral body. It also causes pain in lower back. Spondylolisthesis is very common in lumbosacral region of the spine. L4 vertebra is displaced over the L5 vertebra, that is L4-5 spondylolisthesis, or L5 is displaced over the S1 vertebra, that is L5-S1 spondylolisthesis. In old postmenopausal women, osteoporosis, a degenerative spondylolisthesis, is very common in lumbosacral region due to low estrogen level and decreased calcium absorption. How to recognize lumbar spondylosis? One should not ignore the severe lower backache, and particularly if pain is radiating to lower limb or associated with numbness or weakness of the limb. Investigations like X-ray of the lumbosacral spine and MRI scan of the lower back can diagnose this problem. Sometimes X-ray of the spine in standing posture with bending forward and backward is required to diagnose spondylolisthesis. MRI of the lumbosacral spine is the preferred investigation for diagnosis of cause of lower backache. It will show the alignment of the lumbar vertebrae and intervertebral disc, dural sac, lumbar canal diameter and nerve roots. So even a minimal disc bulge is visible on MRI. MRI can also rule out other diseases of the spinal cord which may also present with lower backache. MRI may exclude other causes of the lower backache like nerve sheath tumors, any other disease of this region like Pott's spine, that is tuberculosis, or multiple myeloma, etc. So, plain X-ray and MRI of the spine are indispensable for the diagnosis of any disease of spine. Sometimes CT scan of spine may be required. What are the treatment options for lower backache? Almost everyone experiences pain after exercise or after a prolonged walk or on exertion. So all cases of mild lower backache need not to be investigated. Treatment will depend on cause of the pain. Usually a strict bed rest, lumbosacral belt and analgesics for a short period of time can relieve symptoms. Sometimes stronger pain relieving drugs, muscle relaxants, and drugs to reduce inflammation may be needed. Many other treatment options are also available. Physiotherapy measures like short wave diathermy Ultrasound therapy, traction, and exercise therapy may help in chronic cases of lumbar spondylosis. Urgent neurosurgical intervention is required if there is high degree of degeneration of vertebrae or if disc is protruded or associated canal stenosis or weakness or decreased sensation in the lower limbs or difficulty in urination. Neurosurgical microscopic discodectomy or endoscopic discodectomy are common surgical interventions. In some cases, like severe spondylolisthesis, spinal surgical fixation with implants is required. Can lumbar spondylosis be prevented? The primary prevention of lumbar spondylosis is possible by regular exercise, physiotherapy, correct posture, and weight reduction. Once diagnosed with lumbar spondylosis, a patient should avoid lifting heavy weight and bending forward. Posture correction, use of correct lifting technique, avoidance of sudden twisting movement of back, use of a cushion at lower back to maintain lumbar lordotic curve is mandatory to prevent progressive degeneration of lumbar spine. There is a role of surgery in management of patient with lumbar disc prolapse. Surgery prevents further deterioration in severe cases. Discodectomy and spinal fixation may treat severe cases of spondylolisthesis and prevent further neurological deficit. Severe cases of disc extrusion should be operated to avoid foot drop and cardia equina syndrome. Other causes of lower backache are spinal trauma, osteoporosis, nerve sheath tumors, infections of the spine, osteoarthritis of the hip joint, primary bone tumors, vertebral metastasis, etc. Although spondylosis is very common cause of lower backache, but some tumors may also present with lower backache. Intradural extramedullary IDEM means lesion inside the dura but outside the spinal cord. It is commonly mentioned as IDEM lesions. Common IDEM tumors are sonoma, neurofibroma, and meningioma. They present with features of nerve root and card compression. So the pain and weakness are the common symptoms. Most of these tumors can be excised and gross total macroscopic resection makes them amenable to surgical cure. The nerve sheath tumors are sonomas and neurofibromas. MRI of the spine with contrast is the investigation of choice for assessment of intradural extramedullary tumors. A dumbbell-shaped lesion traversing the neural foramen suggests a nerve sheath tumor. Spinal meningiomas have the broad dural base and show homogeneous contrast enhancement on MRI contrast. Summomatous type of meningioma is more common in spine. Other uncommon type of IDM lesions are arachnoid cyst, epidermoid, and dermoid. Intramedullary spinal cord tumors. The intramedullary tumors are the tumors which are present inside the spinal cord, that is inside the pile covering and in the substance of the spinal cord itself. This diagram is made to explain you the location of the different membranes around the spinal cord. Spinal cord itself, the tumors which arise from the spinal cord parenchyma are intramedullary tumors. Tumors which arise outside the dura, they are extradural tumors, and tumor just beneath the dura but outside the spinal cord, that is intradural extramedullary tumors. Spinal tumors can be classified as extradural, intradural extramedullary, and intradural intramedullary tumors. Extradural tumors are the most common spinal tumors and are usually of metastatic nature. Intradural extramedullary tumors are mainly neurofibroma and meningioma. Intradural intramedullary lesions comprise 20 to 30% of all primary spinal cord tumors. Gliomas make up to 80% of all intramedullary tumors. The gliomas are further subdivided into astrocytomas and ependymomas. Hemangioblastomas are the third most frequent intramedullary spinal cord tumors, comprising 2 to 15% of all intramedullary tumors. Metastatic intramedullary tumors are rare. Lipomas are commonly associated with spinal dysraphism. Intramedullary tumors constitute about 35 to 40% of all intraspinal tumors in children. In children, intramedullary tumors are mainly developmental in origin, like dermoid, lipoma, and epidermoid. In adults, intramedullary tumors may arise later in life, like astrocytoma, ependymoma, and hemangioblastoma. Half of the central nervous system ependymomas are located in the spinal cord, and of these, 50% are located in the final terminal. The next common site is the cervical cord. Glioblastomas are not common in the spinal cord. Hemangioblastomas are rare, consist of less than 2% of primary spinal cord tumors. Clinical presentation depends upon the site and size of the lesion. MRI of spine with contrast is the investigation of choice. Primary osseous tumors of the spine are uncommon lesions, less frequently encountered than metastasis, multiple myeloma, and lymphoma. Osteoid osteoma, osteoblastoma are rare primary bone tumors. They may also present with backache. Chondrosarcomas are malignant cartilage forming tumors. Chondrosarcoma is the second most common primary tumor of the spine after multiple myeloma. Chondrosarcoma may be classified as primary, arising de novo, or secondary, arising from a pre-existing osteochondroma or enchondroma. Although chondrosarcoma is second most common primary malignant tumor of the bone, but chondrosarcoma of spine is uncommon. It rarely grows inside the spinal canal. The plain X-ray CT scan, and MRI aid in the diagnosis. Radiographically, the tumor is often radiolucent. On X-ray, osteoid osteomas are usually about 2 cm sized with sclerotic rim, and osteoblastomas are usually larger in size. Both osteoid osteoma and osteoblastomas are more common in posterior elements, occurring predominantly in the pedicle transverse process and lamina and spinaceous process. Osteoblastomas may enlarge to encroach the spinal canal. Technetium bone scan may accurately localize the lesion, and it demonstrates an intense focal accumulation of the bone seeking agent. The site of the tumor appears as a typical hot spot on technetium bone scan, but if lesion is already discernible on X-ray films, the scintigram is unnecessary. Spina bifida, spinal dysraphism, myelomeningocele, and meningocele. Spinal dysraphism means a spectrum of congenital anomalies of the spine and spinal cord. Spina bifida is a common form of spinal dysraphism. The term spina bifida includes a wide variety of anomalies. Congenital defect in the spine leads to spina bifida. This can be of two types: spina bifida occulta and spina bifida aperta. If the spina bifida aperta there is a visible lesion like a swelling over the midline of the back may be noticed at the time of birth of a child. Such spinal dysraphism is known as spina bifida aperta. A child may be having some abnormality of the spine or spinal cord without any externally visible lesion and overlying skin is intact. Then it is known as spina bifida occulta. This defect of the vertebrae of the spine of a child may not be visible at the time of birth, and there may be no visible exposure of meninges or neural tissue, and there may be congenital defect only in the lamina of the vertebrae of the spine without any involvement of the underlying spinal cord. This is called spina bifida occulta. In spina bifida aperta, there is a visible or open defect in the spine. There may be congenital defect in the vertebral arches with cystic distension of the meninges, which is filled with CSF and is known as meningocele. If in this congenital defect of the vertebral arches there is a cystic dilatation of meninges and cerebrospinal fluid along with neural tissue or spinal cord, that is myelin, then it is known as myelomeningocele. If meningocele contains a fat, then it is lipomyelomeningocele. Investigation of a Backache in a child involves MRI of the spinal cord and brain. MRI of the spinal cord and brain is the investigation of choice for assessing a case of meningocele. MRI may show whether a swelling on the back of a child is only filled with CSF or does it contain any neural tissue. It detects any intraspinal extension associated with intraspinal dermoid, lipoma, dermal sinus, spina bifida, spinal dysraphism like duplication of the cord, any bony spur between the duplicated cord, cherry malformation, syrinx, hydrocephalus, thickened phylum terminal. So, MRI of the brain and spinal cord helps in the diagnosis and surgical planning of the management, and it also helps in prognostication of the patient. Tuberculosis of the vertebral column is very common disease. The tubercular granulation tissue compresses the spinal cord and presents with backache and neurological deficit. This is X-ray of the thoracolumbar spine lateral view showing decreased intervertebral disc space and a small lytic lesion in the vertebral body in a patient with tubercular infection of the vertebrae. This is the sagittal T2 weighted image of a patient with Pott's spine suggesting collapse of the vertebra and compression of the spinal cord of the dorsal spine. This is axial T2 weighted image showing destruction of the vertebral body and compression of the thecal sac and spinal cord due to granulation tissue. This is the FLAIR image, flow attenuated inversion recovery image of sagittal view of spine showing intramedullary lesion and associated edema in the spinal cord. This is contrast MRI of the lumbosacral spine showing contrast enhancing intramedullary lesion in the spinal cord, suggestive of intramedullary tuberculoma, which was treated successfully with anti-tubercular therapy. Spinal cord is contained inside the spinal canal of the vertebral column. Spinal cord is covered by three membranes: pia, arachnoid, and dura mater. Spinal cord is contained inside the spinal column, which is formed anteriorly by the vertebral bodies and disc and bounded posteriorly by the lamina and spinous process. This is very simple image to learn about the lateral view of the X-ray of the spine and also MRI of the spine, sagittal view. You can locate the anteriorly placed vertebral bodies, then facet joints, then spinal canal and spinal cord. Image of a vertebra showing its parts and location of the spinal cord. This simple diagram explains the different parts of the vertebra like vertebral body, transverse process, spinal canal, lamina and spinous process. In this image you can locate the location of the nerves and spinal cord inside the vertebral column.